Welcome to Pall Mall Cosmetics. I'm Carlita and today I'm joined by Professor Raghavan, our amazing ENT and facial plastic surgeon. Together we'll be discussing all things facelifts, from who may be a suitable candidate to recovery, results and what patients can expect throughout their journey with us at Pall Mall. So stay tuned and I hope you enjoy.
Hello, I am Professor Raghavan. I'm a facial plastic surgeon working in Pall Mall Medical. Today we will talk about facelift, different types of facelifts, and more detailed aspects of each type of facelift. Regarding facelifts, there are so many information available in the social media. Many of them are true and good facts, but there are some spurious facts too. I'd like to clarify those facts about various types of facelifts. And if you have any doubts, I'm more than happy to meet you and have a consultation and explain the type of facelift which will be beneficial for you.
Today we want to go into the different types of facelifts. So could we speak first then about the MAX facelift, please?
MAX facelift, that stands for minimal access cranial suspension. It's a mini type of facelift. When I say mini type of facelift, the incision, the cut you make to approach with a facelift starts from around this side bone and in front of the ear, inside the ear, and comes up to this much part. You don't go behind the ear like usual facelift. And the area we lift the skin from the deeper tissue is also confined to a smaller part. After lifting the skin, we find the deeper layer, the muscle and the fascial layer called SMAS. The SMAS is what we tighten. In a max lift, we use two sutures. They are purse string sutures which start from the top and then goes down just above the upper part of the neck and then comes back. When these purse string sutures are tightened, the SMAS gets plicated. It's folded on itself in many parts like pleats, and that's how the upper part of the neck gets pulled up. And then second suture goes a bit more wider, goes towards the jowl and then comes back. And once that is tightened, again the SMAS is pulled up. That will help in tightening the jawline, reduce the jowls and improves the appearance. So that is essentially a max lift.
Okay, and what type of patients would you recommend have that type of facelift then? Who's an ideal candidate?
So aging process of the face, there are various classifications. The one I follow is called Dan Baker's classification of aging face. So the Dan Baker's classification 1 and 2 essentially means very early stages of aging. A little jowling, the jawline getting obscure because of the jowling, a bit of fullness of the neck. Those patients are suitable for a max lift. Anything more than that, I don't think is get a good result from a max lift alone. So some patients who are in their late 30s, early 40s with the kind of changes I mentioned, they will certainly benefit from a max lift.
Amazing. So what about somebody who's maybe lost a little bit of weight then and have a little bit of sagging from weight loss? Would that be a max facelift or would they require a different type?
Again, it depends upon how much of the changes are.
Yeah.
If a person has lost a lot of weight, then
Yeah.
there's going to be a lot of excess skin and loosening of the muscle. They will not benefit from a max lift. But somebody who has lost, say, 10 kilos, then there will be some slight changes there, a little bit of sagginess and fullness. Those patients will benefit from max. Anything more than that, we'll need for some other procedures.
Okay. And what's the recovery like on a max facelift?
So
The recovery.
recovery. Because it's a minimal dissection and using only two sutures, so I will say that the recovery is earlier compared to some of the other more invasive procedures. Usually about 3 to 4 weeks, they should be able to get back to work.
Okay, amazing. So you mentioned SMAS before. Can we go into that a little bit deeper then and explain what that type of facelift is?
First, to explain what is SMAS. SMAS is a layer under the skin. So we have skin, we have fat under the skin, and then below that there is a layer called a SMAS, which consists of a muscle called platysma here, and then the top part there is a more of a muscle, frontalis muscle, and in between there is a facial layer. So altogether this layer is called a SMAS. And now almost all the manipulations in a facelift involves changing the position somehow, the SMAS. There are various techniques described. One we just mentioned about facelift is also about manipulating the SMAS. But other than that, then the SMAS can be changed by making a bigger fold. So you go underneath the skin, find the SMAS and fold it on itself and suture it. So that again helps in bringing the upper neck and the jawline better. So that is one way of doing it. The other way is people have taken a strip of SMAS out. So there is a gap and then the edges are then sutured back. The effect is the same. So the SMAS is tightened, it's pulled up, and so the jawline and the upper neck looks better. That's essentially SMAS lift.
Okay, so again, like we discussed with the max, what type of patient would be an ideal candidate for that type of facelift then?
Because when it comes to SMAS lift, the incision goes behind the ear into the hairline also. So we can use the platysma, the muscle part of the lower muscle part of the SMAS can be pulled up better behind the ear. So that gives a better neck angle and a better jawline and the jumps. So compared to max, SMAS gives a better result because of the pull on the neck. Patients which are a bit more older or slightly more age-related changes like turkey neck, a lot of hanging skin on the neck, those patients benefit from SMAS lift because we are tightening the neck by going into the neck as well.
So this type of facelift covers obviously the lower face and the neck.
Lower
as well.
face and neck. Yes.
Amazing. So then I guess we move on to deep plane facelift. So can we go into the detail of that one as well, please?
So deep plane means we are going underneath the SMAS. So SMAS lift is about manipulating the SMAS without releasing its deeper attachment, whereas a deep plane we go underneath the SMAS and there are some ligaments holding the SMAS down to the deeper tissue. These ligaments are released, so the SMAS, the muscle, the fascia, the overlying fat pads, the fat under the skin and skin together as a single unit is then mobilized. Moreover, because the ligaments are released, we get much more movement of the fat pad of the face which goes up and then gives a much better result. In fact, it's not only the lower face and the neck, the mid part of the face also goes up. The fat pad which is over the cheekbone, that with time starts coming down, which gives this fold here and also with the fold here which is called a sad line or marrow lines. When this fat pad is released and pulled up and put back in its normal position, the mid part of the face improves, this nasolabial folds and this marrow lines also disappear, and the angle of the mouth will start turning down, which gives a sad expression that also can be straightened up. So a deep plane gives a much better lift. Because there's a deeper tissue, there's a wider area for it to get attached while healing, the results are much more lasting. And because we are releasing the ligament, the results are much better too.
Okay, so this again, we're moving a bit further up the face as well with the movement and the pulling back. So again, what type of patient would be ideal for this? Is it again just an age-related thing, or could somebody younger still have a deep plane?
We can, depends upon what the patient's expectations are.
Yeah.
Severe age-related changes, big neck, turkey necks, lot of excess skin and fat, we can do the deep plane face and neck lift.
Yeah.
It's the same way the incision goes behind the ear, so we are dealing with the neck and we are mobilizing all of the tissues as a unit. A patient who is having early changes probably may not need a deep plane, but if they are looking for a long-lasting result, then probably deep plane is a better option. The results are certainly much better than any of the previous max lift or SMAS lift, but the procedure is much more invasive than max lift or SMAS lift.
And does that come with then a longer recovery for a deep plane?
I will say it's slightly more than the SMAS lift, or certainly more than max lift, because we are doing much more dissection there. The area we are dissecting the neck is small, and then we are going underneath the SMAS and dissecting as well. So again, at least 3 to 4 weeks minimum will be required for a deep plane to be presentable.
Okay, and I guess obviously there's the healing under the skin, but physically, is there a difference between how you would look afterwards with regards to like swelling, bruising, things like that? Do they get more prominent with each, the further into the facelift you go, the max? Is that sort of like a less bruising, less swelling, and does it get more as we move through?
The bruising and swelling depends upon how much of soft tissue you are going to dissect, how much of dissection of the skin is going to be. So most of this where max lift or SMAS lift or deep plane will have bruising and also associated swelling. The difference that will come to the preservation part of it, how it changes that slightly. But all those facelifts where the skin is dissected more, there's a more deeper level of dissection, more invasive part of it, the bruising and swelling is more. And that's what it takes more time for recovery, particularly the bruising part of it.
Yeah, okay. So you just mentioned before the preservation facelift there. So is that quite a new technique, and can we sort of discuss that a little bit more as well?
Preservation, the various preservation techniques have been described. Yeah. The way I practice preservation is slightly different. The purpose of preservation, I'm not preserving it. It gives us a message that we are doing something less. Actually, it is not. The deeper dissection for a preservation deep plane is not just deep plane dissection, it's extended deep plane dissection. So in the deeper part we are dissecting more, but what we are dissecting less is the dissection under the skin.
Right, okay.
So for an extended deep plane or deep plane face and neck lift, you lift the skin all the way from here, behind the ear and all of the neck. Whereas when it comes to a preservation and extended deep plane face and neck lift, the front part is about a finger breadth in front of the ear and about 2 finger breadth there. Behind the ear and the neck dissection is only up to there. All this part the skin is left intact. We are not dissecting it from the deeper tissue. The benefit is that, like I mentioned before, the bruising, the swelling is much less. So instead of going to the deeper layer from here, we are starting the deeper dissection from much more in front of the ear. So that means once the SMAS is pulled back and sutured back, the area where the skin has been dissected is almost nil.
Okay.
That means again less bruising, less swelling. People have described there's a paper by Mike Naik who said about preservation and deep plane. He left a patch of skin here and he said that if you pull on it, the neck all get tightened. That's true. And that's how I practice first. But then I found that some of the patients who have fuller neck, we need to approach the neck from the outer part as well to do a bit of a sculpturing to make it look better. So having a skin attached here is not useful, so we don't do it anymore there. And we realize that we still have the same effect, same pull on the lower part of the neck when you are doing it. At the same time, we can sculpture the upper part of the neck better. So that is how we progress with the preservation deep plane. The other things which I have adopted from other surgeons are people who have been pulling this muscle here and then fixing it to the bone behind the ear. So then another surgeon called Bentalai came out with a technique called mastered crevice. So what he does is that muscle here, instead of fixing here, he goes into the groove here, this part here, and then fix into the groove. That's a mastered crevice, and by fixing it, that gives a much better the jawline, and also it curves inwards. that gives this angle of the jaw much more clearer, that gives a much more youthful appearance.
Okay.
So I have adopted various techniques described by various people and then put together, and that's how I practice a preservation deep plane. So I'm not preserving in the sense of preserving. The preservation is the downtime is reduced. We are preserving the time the patient has to stay at home or stay away from work. With the way we are doing the preservation extended deep plane, the average time for the patient to be off work is about 2 weeks.
Okay, so half then, really, yeah.
In 2 weeks' time, even they are working in front of the camera, they can go back to work. The incision probably is still visible slightly. They can put the hair in front of the ear or can have a bit of touch of makeup. Another thing I have added on to the preservation extended deep plane face and neck lift is there's a hemostatic sutures. So previously when we started, we used to have drains from behind the ear to prevent any blood collecting there. Then we introduced the hemostatic sutures. So those are sutures in and out through the skin. Wherever we have lifted the skin from the deeper tissue, we put those stitches through the skin. It looks horrible, so I show pictures to the patient first to make them understand that this is how it looks, and it's there only for 2 days. In 2 days we take it off, there's no drain, and once the sutures are taken off, there is no scar. I show the patients that 2 days later how it looks like, and people are convinced. The benefit is there is no drain. Because we are putting multiple stitches and holding the skin to the deeper tissue, we are redraping the skin where we want. The shape is better.
Yeah.
There is no space for blood to collect, so less bruising, less swelling, and that helps in reducing the downtime to 2 weeks.
Yeah, that's amazing.
And because there is no drain, I send the patient home the same day, so they can go back to their own bed and sleep.
So we've covered all the different types of facelifts then. So can we just sort of give a summary of the outcomes of each and how long a patient can expect those results to last for?
So we discussed about max lift, SMAS lift, deep plane, and the preservation deep plane face and neck lift. All these facelifts give some improvement to the patient. So the choice will depend upon the age-related changes the patient is having, what they expect and what they want out of it, and how long they want the result to last. Max lift will have the smallest incision. It will have the most subtle changes compared to the other types of facelift. And how long it will last is a bit unpredictable, because there are just 2 sutures having a multiple plication or folding of the SMAS. Each person is different, and how they use the face, they are extremely expressive person using the facial muscles quite a lot, then the result may not last too long. The same goes with the SMAS lift. The results are bit more better than the max lift because we are addressing the neck as well. But again, we are just folding these SMAS. So the amount of attachment it has to the new position is less. Again, depending upon the activity of the patient, it may not last too long. But still they can expect about 5 years or so, generally speaking. Whereas when it comes to deep plane and extended deep plane, as well as the preservation extended deep plane, the dissection is all underneath the SMAS, and we are releasing the ligament so that there is much more movement. And also the whole SMAS is lifted up in a new position, so it has a wider area for it to get attached. So the results are much better. So someone who is looking for the best possible result, then we have to go for an extended deep plane or a preservation extended deep plane face and neck lift. For people who like to have early recovery, I would certainly recommend the preservation extended deep plane face and neck lift is the ideal one, with the same benefit of a deep plane or classical deep plane face and extended deep plane face and neck lift. The way I describe to the patient is we are turning the clock back by 10, 15, 20 years. By the time I put the last stitch, the clock is ticking on. So that particular result is not going to last at that point in time. But if I turn the clock back by say 15 years, and if you are 60 and I made you look like 45, when you are 70, you are not going to look like 45, but that 15-year gain will be there. That is the benefit of a deep plane and extended deep plane, as well as preservation extended deep plane face and neck lift, which possibly I cannot guarantee for a SMAS lift or a max lift.
So we've spoke about facelifts, but we know you are an ENT facial plastic surgeon. So what surgeries would you sometimes recommend for a patient complementary to the facelift that's going to give them an overall result?
So just to clarify about my training, yes, I am an ENT and facial plastic surgeon. My higher surgical training in UK was an ENT, ear, nose and throat surgery. So that way I have had a good access to the anatomy, physiology and working of the face, and that's the whole area I have been working and been trained. And after the ENT training, then I moved to facial plastic surgery, which is also part of ENT now. And because of my background understanding of the facial anatomy and physiology, I find it much more easier to deal with the facial plastic side, again, because I'm dealing with all the face and the neck. When a patient comes to me, probably they may be asking only for a neck lift or a face lift. But I see them, the whole face, so I can see whether they have a problem with their brow, with their eyelids, whether the nose is crooked or something can be done about the nose. In addition to the sagging neck, the jowls, jawline, which mostly patients are complaining of. But on a principle, I don't go and tell them that you got bags under the eyes or you got a crooked nose. I don't say that. But when I demonstrate them the changes we can do with the neck and the face, I demonstrate that in the mirror by pulling it up and show that. When the face improves, most of the patients then say that, can we correct the eyelid bags or can we just make the nose? When they make the suggestion to make it, then I go into details of that and explain to them. Age-related changes are not confined to the jawline or the neck or the nasolabial folds. The upper part of the face, which you are not addressing with any type of facelift, and only the deep plane and preservation deep plane addresses the mid part of the face, otherwise it's only the lower face and the neck. The upper part of the face is not addressed by your facelift. That will need a brow lift or a forehead lift or a plus or minus eyelid surgery. The nose part is not age related almost all the time. Yes, there are extreme ages, there can be some changes, but many other people will have some problem with their noses. That can be corrected at the same time as the facelift as well.
Perfect. So the types of complementary procedures that we could add on then, can we just run through them briefly? So you've got obviously blefts and a brow lift. Would that help lift the top of the face as well as the bottom then?
So the brow lift is about repositioning and reshaping the brow. So it can be either done from here, just along that on a direct brow lift, or you can go from the temple and then lift the brow up. But again, that certainly is not going to address the wrinkles there, for which you may still need a Botox in the long term. There are ways where we can lift the skin off the muscle. The horizontal wrinkles are because of the action of the muscles in the forehead. We can separate the skin from the muscle and lift it up, but once the muscle again gets attached to the skin, the wrinkles will come back. So in the long term for the wrinkles, I certainly recommend going for Botox.
Okay.
Other complementary surgery or procedure which may help with the face and neck lift is fat transfer. With age advancing, there is loss of fat.
Yeah.
And that fat can be supplemented. We can take the fat from the tummy or from the thighs, prepare it, and then use that as a permanent filler. Or your cheek, that's where it is lost, or wherever there is sometimes the temples are hollow, we can fill that with the fat to give a much more youthful appearance. Those are called mini fat transfer. Then there's another fat transfer called nano fat transfer. That is actually for rejuvenating the skin. We inject into the skin, and that helps in reducing the minor wrinkles, pigmentations, and generally makes the skin much more supple and youthful. So that's what also can be tried along with the face and neck lift. And another one is about peels, chemical peels, which also helps to rejuvenate the skin and remove most of the mild to moderate wrinkles.
Okay, yeah. So can we just touch on, I know you mentioned it before briefly about Botox. So obviously there's a lot of non-surgical procedures out there. So if somebody's coming in for a facelift or some sort of, facial plastic surgery, do they need to remove all that before, and then could they still continue with those procedures after facelift or upper left eyebrow lift? Can they still have those procedures afterwards if needed?
If somebody had Botox, particularly for the forehead or for the growth field, I like to see them after the effect is over before considering a brow lift or plastic, because we don't know exactly where the natural position of the brow is. And sometimes the heaviness of the skin is because of the over Botox, the brow is coming down, and once the effect is gone, the brow goes up.
Okay.
Coming to fillers, yes, they need to be certainly removed before there is surgery, because we don't know which of the parts which are deficient, and once the filler goes in, we can make a better judgment whether they need microfat injection.
So that's something the patient will need to keep in consideration, and if they're planning on any sort of facial surgery, they need to be prepared to remove the filler and let the Botox completely remove. So a patient that's had surgery then, can they still have non-surgical treatments afterwards, like Botox, or if they wanted then to have filler in again?
Botox, certainly they can have it, and that is beneficial for the frown lines, brow, smile lines. I think surgically those things are not going to be completely corrected. They will, and they certainly can try Botox afterwards too. Fillers is a different thing. Once we have given the microfat injection, we have lifted all the face and neck, there shouldn't be any need for fillers except say the lips. Those kinds of places they can have fillers. Fillers are generally used to reduce the aging process as a non-surgical facelift, liquid facelift. What I always tell patients is that fillers only fills. In a youthful face, the face is like an inverted triangle. As the time goes by, when the tissues migrate downwards, this inverted triangle becomes a triangle. This lower part becomes heavier, and that's when jowl starts. When you inject fillers along the jawline to mask this jowl, what actually you're doing is that triangle is getting wider because the filler fills. So it can reduce, it cannot reduce, it can only increase it. So actually that area becoming more fuller, adding more to the appearance of age. Whereas when you are doing a facelift and everything is pulled up, we are changing the triangle back to the inverted triangle.
So it could potentially have an adverse effect if you was to start to have fillers back into the jaw. It could undo all the work.
It will mask the jowl, but it will increase the appearance or age-related appearance.
So if somebody's having regular non-surgical treatments like filler, Botox, at what point do they, or would you recommend that they move to a surgical procedure to get those results?
Very early changes you can mask with Botox and fillers, but after some time, the patients themselves will realize that the visit to the non-surgical practitioner is becoming more and more frequent, and the outcome becomes less and less satisfactory. Most of the patients then realize that it's time to go for surgical rather than going with a non-surgical treatment. Again, each person is going to be different when they have that realization that it's time for surgery.
Thank you. So can we just touch briefly, I know we've talked about the surgeries themselves, but what does a consultation look like with you? So if somebody's interested in one of these procedures, obviously they'll get in touch with ourselves and then they'd come and meet you for a consultation. What can they expect in that consultation?
The main part of my consultation is listening to what the patient has to tell me. I will listen to what the concerns are, what changes that they're looking for, and I like to know from them the general condition, how healthy they are on any medications. And once the information I have gathered, then I will examine the patient to see which are the age-related problems. Since we're talking about facelift, I'm talking about the age-related problems. I address the neck, I address the jawline, the marionette lines, the sad lines, the angle of the mouth, and the nasolingual folds, and where the cheek fats are. And then I realized, or I'll examine the neck to see where the fat is. The fat can be underneath the skin, or fat can be underneath the muscle, which we mentioned before, this is SMAS. The fat under the skin can be easily removed with the liposuction, but when there's a collection of fat underneath the muscle, liposuction cannot do it. We have to go surgically and remove it. Most people who have heaviness of the neck have muscle fat underneath the muscle, so they almost certainly will need surgical correction. So those are the things I try to find out by examining the neck, and also how much of a neck muscle bands they have. Then I keep them in front of the mirror and reposition all those tissues and show to them approximate result we can make by lifting all those tissues upwards and reversing the aging process. And that's the time when they start having doubts whether want more clarification about how much it changes and how it can be done and what are the procedures available for that. So depending upon what is beneficial for the patient, then I explain to them what can be done and what sort of results they can expect. If the patient needs a preservation deep plane facial neck lift, I show them where the position of the scars, and I also show them my previous patients' the scars and the before and after results of how it is. I keep a collection of patients on the table the day after the day of the surgery, 2 days later how they look like, a week later when they come how it looks like, and then every 3 weeks, 6 months, so they can see the journey of the patient and they can make up their mind from that.
Okay, but that's really helpful for them. Do you also go through obviously risks to the facelifts, and can we just sort of touch base on them?
So I will explain about the scar, and most of the time the scar is not a problem, they heal quite well. But when it comes to the deep plane, one of the problem is once you go underneath the muscle, we are right on top of the nerve branches which moves the muscles of the face. Close to the nerve, there is always a risk that the nerve can be damaged, most of the time temporary, but there have been reports that permanent damages has been done. That is a risk involved. Personally, in my series of patients I have done, I had 2 patients who had temporary weakness. One had weakness of the forehead muscle and one had weakness of the lower lip. Both of them recovered completely in 2 months' time. So possibly that was because of the spread of heat when you are using a diathermy to control the bleeding. So those kind of problems will completely recover without any adverse effect. But that is a risk that I explain to the patient, that particular risk. For any facelift, the other risk is damage to the skin, particularly the part which is coming here and behind the ear. That's the furthest away from the blood supply. These 2 points sometimes can lack blood supply in people who are smokers, who have any problem with the blood supply like uncontrolled diabetes. Those are patients particularly vulnerable for this. So that's the reason why we don't encourage patients, heavy smokers, to come for surgery unless they have stopped smoking for a considerable period of time. And the diabetic patients has to be controlled and maintain the control for a longer time before we consider surgery. That also is an advantage with the deep plane and the preservation deep plane, because we are lifting the skin with the deeper tissue. The blood supply is much better than a max lift or a SMAS lift.
Okay, so if you're in general good health, then the risks are slightly lower. It's just for those patients that, like say, heavy smoker, diabetes, or generally unwell.
The risk for the skin is certainly almost nil in a healthy people. The nerve damage is nothing to do with the health, it's the procedure problem.
Yeah.
That's where the training of the surgeons and the experience of the surgeons and their understanding of the anatomy come into play.
So we've spoke about the procedures themselves, but can we talk a little bit about you and your experience in the NHS and in the private sector, and obviously the amount of surgeries that you've done?
Okay, my training as in ENT was in Nottingham, Derby and Leicester universities, and after my training I went for an European Academy of Facial Plastic Surgery fellowship, which took me to different centers in Europe and then to US, and then got board certified from the International Board of Facial Plastic and European Board of Facial Plastic Surgeons. Later on, when the Royal Colleges decided to have a certification process for cosmetic surgery, I went for that and got certified by the Royal Colleges, a Royal College certified facial cosmetic surgeon. My luckiest break probably was that immediately after all this training, I was appointed as an NHS consultant to do facial plastic surgery. Most of the facial plastic surgery was about skin cancer, excision reconstruction, as well as nasal blockage from rhinoplasties done elsewhere or from severe trauma to the nose and face. So that gave me an extensive experience and further training in doing complex rhinoplasties, functional and aesthetic. And when it came to skin cancers, it helped me to develop various flaps and understand reconstruction of the face. But I modified that a little bit. Like if there's a skin cancer, which is quite common nowadays, skin cancer over here. Instead of doing a local flap or putting a skin graft, I was trying to mobilize the whole tissue like in a facelift and then close the defect without any other additional scars from the flaps or a skin graft. So people liked it, the patients liked those kinds of things. So that helped me get more experience in various types of facelift to mobilize the face to close various skin cancers. The same way I did for the lower eyelid and upper eyelid. For lower eyelid again, instead of putting flaps or grafts, I have tried to take away the bags when they have bags so that leaves more skin there, so I could close the defect without having additional skin recruited there. So that gave me more experience with the lower lid, the same with upper eyelid as well. And with the NHS, autoplasty, the pinning back ears, that's approved for NHS. So all those things gave me a wide experience in various aspects of facial plastic surgery, both reconstructive, functional and aesthetic surgery of the face. That helped me to set up my private work. Even though initially I was doing private work a few places, then I realized that working for Pall Mall Medical suited my experience, as well as the working atmosphere was also more suitable for me. So I decided just to confine my facial aesthetic work only in Pall Mall Medical.
So if somebody wants to come and see you, they can find you here at Pall Mall only for those facial plastic surgeries. Okay, so if you're not in the UK and here performing cosmetic surgeries, you're travelling abroad for conferences and training. Can you tell us a little bit about that as well, please?
So my experience at the NHS and the private gave me enough material to publish various papers on various aspects of facial aesthetic and reconstructive surgery. Probably it's because of that I've been invited to give guest lectures in various countries, in various meetings, as well as demonstrate this kind of surgery, live surgery, as well as on cadavers. So that has happened in various countries, and I'm from India, so quite often I go to India, and some of the universities there wanted to appoint me as a professor in facial plastic surgery. The premier institutes in India, All India Institutes of Medical Sciences, where I have been invited, and almost every year I go there. They wanted to give me a visiting professorship there, but the rules and regulations prevented that, particularly with the age, and they don't have a concept of honorary professor. But there are other medical universities, which one of them is SGRD University in Ullas, a city in India. They made me an honorary professor in facial plastic surgery. So other than going to different countries, more and more younger surgeons are coming over to be an observer as well as to get trained, hands-on training with me. Previously they used to come to NHS as well. Nowadays more and more people are coming to Pall Mall medical for seeing various facial aesthetic surgery.
So what benefits would a patient then get from coming to you as a specialist facial plastic surgeon in compared to a general plastic surgeon then?
I don't think a specialty matters much. The boundary between various surgical specialties is getting more and more blurred. I will say that the essential part is who is better trained in which procedure. I'm sure there are a lot of general plastic surgeons who are trained well in the face, but as a ENT turned facial plastic surgeon, my exclusive insight and knowledge is about face, and that's what I do every day. That gives me an advantage. I'm not saying that others don't have an advantage, but being exclusively doing with the face, I have an advantage to deal with the facial aesthetic and reconstructive surgery, and my training has been confined to that too.
Okay, so leading off from that then, can we think about sort of, you said obviously you've got a lot of experience in the face, and is that from doing obviously a number of procedures? Are you doing more and more face lifts at the minute? Are they becoming more popular? Is it a surgery that you find you're doing more?
I've been doing facelifts for the last 20 plus years. I've tried with the various lifts which we had discussed already, from max lift to SMAS lift to deep plane, and then now to preservation extended deep plane. After going through all those various techniques, now I confine myself mostly to preservation extended deep plane face and neck lift, and some extent max lift if the patient insists on it, or if there are very subtle changes they are looking for. These are the two things which I do, but all the 20 years the experience has accrued, and that gives me more confidence in dealing with the facelifts.
Well, thank you for that, Professor Raghavan. And what would you say to anybody then that on a final note that's considering a facelift? Is it beneficial to just come and speak to you, have a consultation, and how can they do that?
More and more people are becoming conscious about the appearance of the face. It may be an influence of the selfies and the Zoom meetings. Certainly there are more people coming looking for facelifts to my clinic. If you're considering, or if you're even thinking about having a face and neck lift, I'm more than happy to meet you in Pall Mall Medical, and then we can have an honest discussion about whether you need it, and what type of facelift you need, and how much of differences that can make your face.